A very good morning to everybody, and thanks for having me here for this ISMPO, and thanks to the entire team for bringing all of us together. Okay, can I share my slides?
Ma'am, please share your screen.
Okay, I'm sharing now. Okay, is it visible?
Yes, please full screen it, ma'am.
Yeah. Yeah. Yes, thank you. Okay, I just also quickly invite our panelists. Okay, now ovarian cancer, as you know, has most of us we detect in a very advanced stage with a lot of peritoneal disease, disease, ovarian ascites, and then nodal disease as well as distant metastasis. And that's where the problem is, and we are facing most of them at a very advanced stage. And yes, definitely outside metastasis, which brings you all bit of a problem. So that's why the results are very less with all our patients, and we face the survival deficiency. Now, let's coming, having said all about this, and that's where the research is how we can improve our diagnosis and treatment of these advanced metastatic ovarian cancer. And the anatomic pictures tells us how grave the disease is. And also the incidence in India is also, may not be as high as the Western, but is definitely rising. And with age, there's an increased risk. Having said this, let's get into just exclusively, we restrict ourselves to the clinical review. Okay, now quickly question to Dr. Smita. Okay, do you at any point of time differentiate what type of ovarian cancer you are looking for?
Yes, ma'am, definitely. Most of the commonly we see is the epithelial ovarian cancer. Very rarely we see the endometrioid, the mucinous, and it's also important because the mucinous, the response rates are poorer.
Yes, please.
The types of chemotherapy, which is you see the types of ovarian cancer, and also we have to keep in mind in young patients, germ cell tumor.
Yeah, germ cell tumor. Yes, definitely is right. And if you see the recent NCCN guidelines upfront, they have different treatment, almost the same, but they do differentiate it with the type of histopathology you are getting. So still histopathology holds good as far as ovarian cancer is concerned. Now, Dr. Krishna Kumar Ratnam, taking into consideration, we are going to discuss only about the recurrent and metastatic ovarian tumors. Do you think any molecular diagnosis are you doing in your practice, or if not, what are the molecular tests that is needed?
Regarding the molecular diagnosis, as of now, we have been doing the HRR, which is still not exactly in the guidelines. So BRCA1 or 2 in selected patients who are having a high-grade serous ovarian cancer is being done. And other than that, I have not started using NGS extensively in my practice, although very soon we may be having a lot of molecules which are going to roll in for, say, the RAS mutant or the other pathways which are activated. But otherwise, and even the MSI, still we don't have clear data as far as the use of immunotherapy. So in my clinical practice, it is only BRCA1 and 2 which I've been following for patients who are platinum sensitive, or if possible, any high-grade ovarian.
Yes, you're absolutely correct, and this is it's a little older paper which tells us yes, there are potentials of many molecular, but if you see the latest guideline, the approved techniques are molecular. It's not only BRCA1, BRCA2. Yes, you do an HR status, rightly you said. MSI is included, tumor mutation burden is included, and NTRK is included. Maybe we don't have drugs, but if you really, theoretically, if you want to discuss, these are couple of parameters with the NCCN guidelines says BRCA1, BRCA2, HRR, MSI, tumor mutational burden, and TRK. Okay, that is yes, due to logistics, many of us will not be doing. Now, Anita, okay, a quick question to you. Whom do you suspect, and or when will your high level of suspicion for a familial ovarian cancer syndrome? To which particular patients in a recurrent and metastatic disease? Amita is there? Amita Maheshwari? Amita, please.
Am I audible?
Yeah. Speak, please. I hear you.
So you want to know how do we decide whom to send for genetic testing? So our current practice is, if possible, to send all non-mucinous epithelial ovarian cancer for genetic testing, if possible. But apart from that, if we still have to, narrow down, so it will be younger patient with family history, and in recurrent setting patients who have long disease-free interval. These are the patients whom we would definitely try to get
Would
a
like to
genetic
do.
test.
Okay, and we stay back with you, Dr. Amita. Okay, now a patient has come with a huge abdominal mass. What would be your staging things to rule out operability?
So, if I put it broadly, there are three major factors we need to take into consideration while deciding between upfront surgery versus neoadjuvant chemotherapy. I think that's the question. So, one is patient-related factors, performance status, albumin, any comorbidities, age of the patient. So, these are some of the considerations whether patient per se will be able to withstand aggressive surgery or not. The other is disease-related factor. So whenever a surgeon feels optimal cytoreduction is not possible based on imaging, so suppose disease in stage 4 disease or liver parenchymal metastasis, extensive carcinomatosis, upper abdominal disease, or pulmonary metastasis, or mediastinal lymph node. So all these are the factors where optimal cytoreduction will not be possible. And the third and very important in our kind of setup is infrastructure related factors which we need to consider. So it's just not about surgeons. You have to see overall setup and patient's financial status also, and your surgical wait list. So these are three major components which we take into consideration while deciding between upfront surgery versus interval debulking.
Yes, so it's basically a clinical, radiological, pathological, and financial and logistics also involved. And just a quick comment for the importance of surgery in low advanced disease.
Yes, surgery is the essential component of ovarian cancer management, be it early or advanced. So I think the question is not to do surgery or not, is the question is about the timing of surgery, whether we do upfront surgery or we do after neoadjuvant chemotherapy, because we have fairly good data now suggesting that if we do the surgery after neoadjuvant chemotherapy in advanced cases, survival is the same, and post-operative complications and mortality is reduced with neoadjuvant chemotherapy. So.
Okay, thank you so much. Now, coming to Dr. Ajay Yadav, do you also, as I mentioned to you, this was a recurrent case, do you also classify your patients as platinum resistant, refractory, sensitive?
Yes, ma'am. If the recurrence is after say 12 months, then it is platinum refractory disease. If it is between 6 to 12 months, then it is platinum sensitive. Refractory.
Yeah, okay, sensitive greater than 12 months, and if it is less than 6 months, they are the only difficult people to treat with. Okay, next coming to the and now if you take Dr. Saurabh, now this our patient, I showed the picture. So as per Dr. Amita, what the point she mentioned was applicable to our patient. So what would be your choice of drugs?
There is no recurrence, ma'am.
This patient with the recurrent and the mass in the abdomen, okay, what would be the choice of your drugs to start? As we taken a consultation already with the surgical and a gynae oncologist. They said these are not the case to be operated on.
Choice will be a vaccine with a platinum agent. That is the most important thing. After third cycle, as Amita Maheshwari madam said, for 3 cycles or 6 cycles, when the surgeon thinks there will be an R0 resection or resection will be possible, we continue till then, as long as it is sensitive. So my thing would be a taxane with a platinum agent.
Okay, and now if suppose if the patient has come within 6 months of giving up taxane and already, what would be the choice of drugs?
It's a very difficult thing. Once it's platinum refractory, the options remain between liposomal doxorubicin and gemcitabine. Addition of bevacizumab also might help in this situation. Sending for additional markers, including PDL1 testing, would be an ideal situation. BRCA1, BRCA2, as Dr. Krishnamurthy was mentioning, that is a very important factor once you have platinum refractory disease.
Okay, Dr. Amita, coming back to you, see, initially we saw that minimum residue 1 centimeter, then it came to 0.5 centimeters, and now they say that there should not be any residue. So, quick comment on that, and also, which patients after completing the surgery would you ask for an HIPEC?
Okay. So I think this concept of optimal cytoreduction has been a moving target. It, in fact, started from 2 to 1.5 to 1 to 0.5 and no gross residual. And I think what we understand that if there is no gross residual disease, that's the best scenario. But if not, at least less than a centimeter we consider as optimal cytoreduction. And this definition may be slightly different in neoadjuvant setting, where goal should always be to achieve no gross residual disease. Coming to the point of HIPEC, so current evidence in frontline setting, that means if surgery has been done upfront without neoadjuvant chemotherapy, there is no good evidence that HIPEC works in these patients, and also need to consider morbidity, because surgeries in upfront setting generally more extensive and morbid. Trial is ongoing. We expect result in not before 2026. So till then, I would say there is no evidence. And if you want to practice, you should do in a trial setting. What evidence we have for HIPEC is after neoadjuvant chemotherapy in stage 3 patients. And OB HIPEC 1 trial, which has shown improvement both in OS and PFS in these subset of patients. Although I must say this trial has been criticized for many reasons, including small sample size around 250 patients, and there were many logistical concerns also. But if we want to practice based on evidence, I think this will be the patient population where after interval deal bulking surgery, you are able to achieve optimal cytoreduction. One may consider HIPEC using cisplatin, and in the protocol it was 100 milligram per meter square of cisplatin. So these are the patients.
And in an advanced and a recurrent scenario, when you have achieved an
yeah, so recurrent scenario, again, there is no evidence. Currently, in fact, recently a phase 2 trial was published from MSK using carboplatin for HIPEC, and it actually failed to show any survival benefit, although the study showed that HIPEC was tolerated well in these patients. So I would say currently, again, there is no evidence for HIPEC at recurrent disease.
recurrent metastatic role
secondary site reduction. So the only scenario where we have some evidence is NACT-IDS, where optimal surgery is achieved.
Actually, that's the area that you give, but we need to remember it's costly also. And sometimes it will be a plus around, bigger center is around 10 lakhs almost it is. And it is also time consuming, longer hours of anesthesia. Yes, so that's one point. Coming to Dr. Nadeem, okay, then let's have a quick discussion on the intraperitoneal chemotherapy. What is that? How are you placing it in your practice now?
I mean, ma'am, to be very honest with you, we don't have at our center available this intraperitoneal chemotherapy, and moreover, if we look at the available data, what we can see, as you have already pointed out, the logistics remains always a big concern, and moreover, whatever trials have been carried out, most of the patients couldn't complete the scheduled chemotherapy. So, practically speaking, I mean, at least we are not practicing it in present scenario. I mean, this intraperitoneal, and most of our patients, they are not even able to afford for it.
Yeah, it's a little cumbersome. Even I don't do it in my medical college, but yes, some of the private patients I do, because you need to have a catheter put, and they have to. There's a day 1 and day 8 intraperitoneal is also there. So yes, logistics are involved, toxicity is high, cost is also involved, and so we are restricted to limited. But then intraperitoneal chemotherapy also is still there as its role. Now, quickly, this slide shows you what are the drugs which I asked already earlier to you. Okay, that you can, Dr. Siddharth, quickly before we move on, You have failed in your Taxol and platinum. What in your current practice, what are the chemotherapy drugs you are using? Patient is in a good general condition. Surgeon says, yes, you reduce the tumor, I might be able to take it out. Second look surgery is possible. So what are the drugs? Dr. Siddharth? Or Dr. Anuba, anybody can take the question.
Good afternoon, ma'am. So if the patient has already received a taxane and we're not considering a taxane, there are various other options that include gemcitabine, liposomal doxorubicin, and among others. Those would be the first, second line that I would use. And then after that, you would also have agents like etoposide, topotecan, role of trabectedin, little bit. I've also used ifosfamide with a taxane with good results. And then coming to even third and fourth line settings, there is some small data retrospective for things like pemetrexed, capecitabine, melphalan. And I would also say over here, if it's not somebody who I'm thinking about surgery, but just prolonging and palliative, I have also used metronomic chemotherapy in this situation.
Yeah, small dose to continue for a longer time. Yes, now these are some of the combination. We can go for gemcitabine and then liposomal doxorubicin. Okay, now quickly coming to Dr. Siddharth is joined back with us. Okay, role of bevacizumab in the tumor of an advanced ovarian cancer. Dr. Siddharth. Okay, then we continue with Dr. Anuba. Okay,
Yeah.
where do you use bevacizumab? You have seen the GOG 0218 trial. Okay, and
So, ma'am, I think that bevacizumab definitely has a role to play in patients. If we haven't especially used it upfront for your, locally advanced or stage 4, I do tend to use it in my second line setting when the patient has recurred. In combination, we have to remember that it depends on whether the patient is platinum sensitive or platinum resistant. So if I'm using it platinum sensitive, my combo with the bevacizumab should be a taxane, carbo or a gem carbo. In the platinum sensitive, usually you don't want to combine the liposomal dox carbo bev, but if it is a platinum refractory, then you could combine the bevacizumab with any agent, gemcitabine, liposomal doxorubicin. And usually we have to be careful. If the patient is going to be taken up for surgery, you have to stop it 6 weeks before, and when you reintroduce it also, you have to have that gap of 6 weeks. Otherwise, if the patient is not being taken up for surgery, I've used it in my maintenance setting. Having said that, we have to know the BRCA status. So if the patient is BRCA mutated or HRD, then there is a role of not doing bevacizumab maintenance and putting the patient on a PARP inhibitor.
Okay, Dr. Nadeem, okay, have you incorporated the use of bevacizumab in your practice, and do you follow these guidelines as mentioned here and also mentioned by Dr. Anuba?
Yes, yes. Yes, ma'am. We do use bevacizumab, but whenever I do plan a patient for a bevacizumab, I want to make sure whether the surgeon is going to operate on the patient ever or not. Because that part is really very important, because the way bevacizumab interferes in the surgery or in the wound healing. So that one has to be very clear regarding that point. And then next point is that regarding bevacizumab, although in newly diagnosed where we do plan for interval cytoreduction, in that case, I will avoid for this bevacizumab. But in the relapse setting, yes, definitely I will always explore for this bevacizumab. And then coming on to the dose, most of the time I have been using this 7.5 milligram only per kg, not the 15 milligram per kg. And then besides that, most of the time I haven't encountered any major complication with the bevacizumab.
Okay, and if you see the this chart, which shows that almost all patients are benefited, like how you said, stage 3 residual disease, stage 4 recurrent disease. Dr. Saurabh, role of PARP inhibitors. Dr. Saurabh, please.
Ma'am, as a maintenance treatment, post therapy in PARP, if it is positive, we can give PARP inhibitors. The second is, of course, BRCA1, BRCA2 mutated patients. You can give it if a recurrent disease is there. So these are the two things for PARP inhibitor. I think PARP inhibitors will come up further way in the future. As of now, we have both available. Olaparib and rucaparib both are available. They have their own set of toxicities and side effects, but most patients do tolerate them. Some at a lower dose, to be very frank. Some do not tolerate. Basically, to be used as a maintenance in complete response In certain situations where the patient is in advanced state, they want some treatment, maybe using a palliative setting also. But basically, indications are only for maintenance and BRCA mutated patients.
So you mean maintenance chemotherapy? How do you define maintenance chemotherapy?
Suppose
Maintenance.
where there is
Definitely in
complete
stage one,
response,
stage two. Tell me, please tell me.
a complete response and there is no residual disease, the best thing to go, you can give this and it has been found to improve survival. This is more important for BRCA mutated, but irrespective of BRCA, especially rucaparib has been observed to have a benefit for patients in giving. This is after a complete response with our routine chemotherapies.
Yeah, so in an advanced disease and with stage 4, okay, into remission, we can continue maintenance. Dr. Ajay, okay, what about second, in a recurrent disease, okay, in a recurrent or second time you are treating the patient, how do you give the maintenance? Second.
Definitely, if the patient is having BRCA1, BRCA2 mutation or having HR deficient, then we should use these PARP inhibitors because they have shown significant improvement in the PFS. And the main concern in ovarian cancer is recurrence of disease. So in all patients having these mutation positive, PARP inhibitor should be added as maintenance treatment till progression or intolerable toxicity. If patient is
in second line, do you want to do BRCA1, BRCA2, or in second line we just give the drug without
testing? I would advise upfront in all patients NGS for looking for BRCA1, BRCA2.
Okay. Now, okay, coming to Dr. Krishna Kumar Ratnam, is there any role of immunotherapy? You know, nothing is complete without immunotherapy.
True, ma'am. As of now, the role is very debatable. If you ask in my clinical practice, I hardly ever use immunotherapy in the ovarian cancer setting. And I would also be interested to wait and see what's going to come up. But I don't use much of immunotherapy in my practice.
Okay, but if you see the NCCN guideline, MSI and tumor mutational burden is a part of the molecular diagnosis. So how do you look the way forward?
Yeah, pembrolizumab in patients who are TMB positive probably would be the way forward as we go. But still, I think I would be unlike settings like the NSCLC and other places where we have robust data, I think for ovary we'll have to wait a bit.
Yes,
for
we have emerging data in endometrial cancer, okay, with the molecular classification, but yes, paucity of data is there. But then there is also a role of immunotherapy once you have exhausted all your other options and patient is in a good condition and they want some treatment. Yes, it is there as one of the important armamentarium in the treatment of the ovarian cancer. Okay, coming back to Dr. Salnagna, few concluding remarks from you of the overall conclusion of these studies. How we are discussing, anything else you want to?
The basic thing is it's very important to know the stage of the disease. If it's a stage 3, stage 4 disease, advanced disease, usually we prefer to go with the neoadjuvant chemotherapy, usually with a taxane and a platinum backbone. Then always aim for an optimal cytoreduction. Optimal cytoreduction patients, if the patient is fit, young, we can always try for intraperitoneal chemotherapy or intravenous complete the chemotherapy cycles with bevacizumab if there are no contraindications. Do a NGS panel for the BRCA testing for any high-risk patients and the HRD. And if they have, one thing is ovarian cancer always is a bad disease, it will always recur. So we should keep the options open for extended period of treatment. And PARP inhibitors has been a boon in the way that we can use it as a maintenance for patients who have optimally been cytoreduced in complete response and having BRCA mutation positivity.
And we have newer drugs in the second line role of
so in the relapse setting, it's important to know if it's platinum sensitive or platinum resistant. If it is less than 6 months, use another different group of drugs other than the platinum. Try to make the disease more platinum sensitive by that 6 months time. And once they are platinum sensitive, always re-challenge with the platinum.
And one quick question. See, if you read the literature, people do undergo second cytoreductive surgery, even third cytoreductive surgery. So in your practice, how far have you gone and done in how many times?
So we have gone till secondary cytoreduction to second time. Third cytoreduction, usually I think the patients will be with a very bad general condition or performance status. So patients do well if you are able to do a secondary cytoreduction and try to again debulk the disease and then give them another chemotherapy option and then maintenance. So third cytoreduction usually in our settings we have not done. Till secondary we have gone, ma'am.
Okay, thank you. Now, a couple of questions in the chat box before we sign out for today. Dr. Govind Babu, to everybody, surgery can be done safely in 2 to 3 weeks time after stopping in the BRIGHT study. Dr. Amita, how comfortable are you with the BRIGHT study data to do it within 2 to 3 weeks time?
So let me be honest, we have very limited experience doing surgery after BEV because in our practice we don't give a neoadjuvant setting. So I have very limited experience, but I guess in a patient who is otherwise fit after 3 weeks, it's a reasonable option in view of the evidence.
To be safer side, because and see, bevacizumab is not that easy drug, though it is little easily available nowadays. I have seen all complications of bevacizumab, starting in ovarian cancer, starting with perforation, thromboembolic manifestation, bleeding, renal failure, anything you mentioned is already there. But
yeah, so in operative, our main concern is healing related to an intraoperative bleeding, and especially if patient requires bowel anastomosis, and all the concern would be, a leak. So
yeah, thank you very much. If does any one of the panelists wants to add any other point which we have not discussed, you're free. And before we hand it over to the organizers, I think we are right on time. Thank you very much. Thank you very much.